With this session update, I'm Shannon Lurkey. Lawmakers debated a bill to extend the Minnesota Premium Security Plan, also known as reinsurance, through the year 2022. Reinsurance was enacted in 2018 in an effort to lower health insurance premiums in the individual market. Here are some highlights of the Senate debate.
Senate File 694 is the bill that extends the reinsurance for the benefit year of 2022. If you remember, back in 2016, the Affordable Care Act had a program similar to the reinsurance program, and that sunset at the end of 2016. So when we saw the rates come out for the individual market on health insurance, we saw premium increases up to 49%. We saw some counties that didn't have any insurance providers, others only had one, and some had a couple, and there was a very limited number of policies available. So what happened is the individual market basically collapsed. So at that point in time, the House and the Senate put together legislation to create a market stabilization program, which we referred to as reinsurance, and that was put into place in 2017. And what that does is there's an entrance and an exit, and so the insurance companies, if they have a client or a constituent that gets hits 50,000 in medical costs, they go under the reinsurance program, and the state would pay 80%, and the insurance company would pay 20% until they got to 250,000. At 250,000, there'd be an exit and go back into the insurance company. At that point in time, there was a application for a waiver called a 1332 waiver. There were two parts of that waiver. One was for putting the program together. The other one was for the I can't think of the term right now, but it was for another piece of it, and the BHP, the Basic Health Plan, was the second portion of it. And under the BHP, we were asking for a waiver because if you put into a program that reduces the health insurance premium, when you do that, the federal takes a look at that and they take 95% of that reduction, and then they reduce the amount of money that you're going to get from the federal. So we did ask for a waiver for that. The CMS, they approved both waivers back in 2017. It's a 5-year waiver. However, when it was submitted to the Treasury for payment, the Treasury Department decided that they were not going to pay the BHP portion of it, and so we were only paid part of that waiver to start with. One of the conditions was, in order to receive that waiver, is that we had to have the program fully funded as if there would be no help. And so that was estimated by the Department of Commerce to cost $271 million per year, $542 million for the biennium. So at that point in time, money was taken from the Health Care Access Fund along with the remaining money from the MSHA account, and that was put into this account. The numbers ended up being quite a bit lower than that for reinsurance. And so the account that holds that money still has 200 and some thousand in it. In fact, it has 215,000 left in that account, and that is the premium security account. And after we make the payments for the current year, it shows that under the fiscal note we'll have about $104.5 million left there. Also, the money that we've been getting from the federal government for the waiver has been running anywhere from 100 plus down to the last estimate was 86, and now we did get a correct estimate for the payment for 2021, and that is $77.7 million. They also, in the fiscal note, included $1.3 million for accrued interest. So there's going to be a total resource of $183 $0.6 million left, and the projected of the cost of the program is going to be $209.8 million. So we're going to be in arrears about $26 million. So there can be an appropriation down the road to take care of that, or the law reads, or the statute reads, that if the funding is not fully there, that the Minnesota Comprehensive Health Association, who manages the reinsurance program, can adjust the schedules as far as the ramp to get in and the ramp to get off. So there's a couple of options we can do there. So what we found is that this has worked very well. When we started this program, like I said, there was some counties didn't have any representation, others had a small representation with very few policies. In 2000, for the 2021 market, we had 6 providers that were willing to provide insurance. All counties have at least 2 companies, and all counties have at least 20 different options of policy. So it's been fairly successful, and what this will do is we've already used 4 years of the extension, including 2021, and so this will extend it through the 5th year for 2022.
This isn't a temporary fix. It's temporary, but it's not a fix. I think Senator Wicklund mentioned earlier, maybe it was Senator Port, mentioned that most of the people in the exchange are buying bronze plans. And for those who don't track it, they have these, quote, metal names for things. The more precious the metal, the better the plan is. Platinum, that's really valuable. That's best plan you can get. Then you get gold, then you get silver, and these are bronze. I think some of us think these are more equivalent to tinfoil plans or something. It's not really health care. There are people who have thousands and thousands of dollars deductible before they get a penny of coverage. After they're paying, as Senator Port mentioned, $20,000 in premiums. That's not health care. It's not logical. And what are we doing about it? Well, this deals with 3% of the people who buy in the individual market. We're going to give them a few $100 million maybe to buy down. We're giving it to the insurance companies, not the people who are paying the premiums. Giving it to the insurance companies with their multi-million-dollar salaries that we don't want to talk about. We're giving it to them in the hopes they're going to bring down rates. And what are we going to do next year? Senator Dahms, I asked in finance, you didn't seem to have a plan for next year. Oh, we'll deal with next year. But this isn't a fix for anything. Our system is broken before COVID. A poll out last year suggested 45% of Minnesotans, almost half, denied themselves health care that they felt they needed because they couldn't afford to pay the bills. 45%. We don't have 45% uninsured. Those folks were insured. They were insured with things we call bronze plans. And they were getting these wonderful insurance company subsidies, which are supposed to bring down the rates and make them more affordable. But this isn't a fix. It's not a fix for the 3% of the people who buy these plans. It does nothing for the other 97% of us. When almost half of Minnesotans are not getting the health care they need because of cost, we got a problem.
They remember the pain when premiums were going up 25, 35, 40, 50, 60%. That's a crisis. That was a problem. What was interesting, though, is that Minnesota had a comprehensive health association program prior to the Obamacare. Prior to that, we had a need even then. We had a need then where people with pre-existing conditions found that the premiums for their insurance were highly expensive. And so this was before Obamacare, before that, the recognition of assisting them and helping them to have insurance, and especially more so on a catastrophic basis, the kind that puts you on welfare, the kind that takes away your business, the kind that takes away the resources that you've saved for. This program is a reestablishment of what Minnesota had. For many decades, we had this program. So this isn't new to Minnesota, but when Obamacare came in, that became outlawed. We couldn't do that. So now we got a waiver, we have a way, we have a method, and yes, it is a year by year, but to those people, as you all know, you renew your insurance a year at a time anyway. So a year and a year and a year as we look forward to a long-term and a longer-term solution.
The health insurance industry is one of the industries that has fared very well in the course of the pandemic. And when you look at their earning reports, they're doing very, very well. At the same time that Minnesotans continue to struggle to pay for their affordable health insurance premiums under the proposal that we're looking at today that's been in place now for 4 years. This will be its 5th year. So today we are talking about sending another bucket of millions of dollars to the health insurance industry in order to buy down marginally the premium rates for people in the individual market. And I think it's important for us to center that in the context of our history, because before the Affordable Care Act, we were subsidizing the health insurance industry through the MCHA, the Comprehensive Health Insurance Association, and there we were pooling together people with pre-existing conditions because the law allowed, we know this, for insurance companies to deny coverage for people with pre-existing conditions. And as Senator Kiffmeyer reminded us, we are good people with decent hearts. And so Minnesota went about, and it was a Minnesota program that went about the business of creating a high-risk pool for people who were sick and had been denied coverage in the private marketplace. We did that. And we paid for it mostly through small employers and the commercial marketplace. They were the ones that bearing the cost for the fact that the law allowed our health insurance companies to deny care for people who were sick. Now, think about that for a second. You know, it's the past, of course, but we set up a healthcare marketplace that said it's okay to deny people who are sick, deny their access to care. That's goofy in and of itself. And when we forward fast now, past, you know, the years since the Affordable Care Act has been in place, when we allowed people who had been in that comprehensive risk pool to go into the market and into the insurance market, the individual market, then the actuaries did their math and they said, holy buckets, we can't afford this. We need help. And so we stepped up as Minnesotans and said, okay, we're going to send you some money. We're going to subsidize the insurance industry again for them to do the job that they're supposed to do under law, which is to provide coverage for people who are sick so that they can get the health care that they need. So I think if we think about where we're at right now, what this bill is doing is once again sending millions of dollars to the health insurance industry for them to do the job that they're supposed to do. Because we're so wed to a healthcare marketplace that we will continue to spend state and federal dollars to prop it up, instead of doing the hard work of recognizing that there are lots of dollars, federal dollars that go to employers who provide employer-based coverage to offset their costs, lots of dollars that are going into the private marketplace to prop it up so we can hang on to the idea that we have a private marketplace that some believe is superior to something run by the government. I think that's a false argument, and if we were really fighting for Minnesotans, we would get over that ideological divide.
I'm still new here. I don't have all the history on this. So I asked, it was my understanding that this is a bridge. This was a bridge to get us from an unstable market into something long-term, something that served the people of Minnesota. And so I asked, what comes after this? What comes next? And Senator Dahms told us that this is the answer. This is working. This is what's going to keep on happening. This is the plan. And I go back to thinking about Minnesotans who are struggling to pay for the cost of health insurance, not even talking about the cost of health care. And we owe our communities, we owe them a long-term solution that allows our families to plan for their care and to plan for the unexpected, that they don't know when it will come. And they need to be able to access that care when they need it at a price that they can afford.
Let's keep in mind that Minnesota does not have the structure at this point to go to a single-payer program, and so we need to be making sure we can do the best we can. And I think that this bill helps, it certainly has helped the individual market, and keep in mind the individual market has a higher percentage of high-risk people than most markets do, just because of the spread and the small number. There's about 160,000 people in the individual market.
There being 39 ayes and 28 nays, the bill is passed and its title agreed to.
To continue following these issues and more, watch legislative coverage Monday through Friday on the PBS Minnesota channel or visit our website, www.senate.mn/media.